So obviously we've joined on my Facebook, my profile, personal profile, in my group, the Fit Amputee Movement, also on LinkedIn and also on YouTube. So I wanted to welcome Andy Graham to the live stream. Andy's recently finished his PhD in phantom limb pain, but you were a OT before that. So obviously, thanks again for agreeing to come on, Andy, and apologies for the technical difficulties before that.
No problem, James. Yeah, thanks for having us. Thanks for having us on. So, occupational therapist by background, but I've found my way into a specialism in phantom limb pain, which hopefully should be of interest to people in the groups.
Well, I think it's probably you either sit in one camp or the other. Obviously, for me being of congenital, I think most people assume they see the prosthetic. Oh, James, do you suffer with the pain? It's like, well, no, but obviously, if we put that to one side, it's for those that are limb loss, it can be very problematic. For some people are not going to experience it. Some are going to experiencing a lot of discomfort, and it's like a massive bigger spectrum when it comes to pain. So for you in particular, Andy, what was the fascination to want to do your PhD in such a topic?
Yeah, thanks. So you're totally right when we say it's like on a continuum, isn't it? From some people might be experiencing it on a daily basis throughout the day. Others might be little prangs, flare-ups of phantom limb pain, or as you say, sounds like in your experience, not at all. So what brought me to the specialism in phantom limb pain was working so I worked in the NHS in the UK in amputee rehab, and for me, I was working with amputees, a couple of days after the operation, and they were starting to describe, sometimes it was phantom sensation, sometimes it was strong phantom pain, but there was a definite kind of picture that this is a problem. This is pretty much everybody's telling us that they're experiencing some form of phantom limb pain. And as a clinician, obviously, as an occupational therapist, it was, that kind of just inbuilt need to want to help with it. But then when I went to kind of look at the guidelines and to look at, how I can assess and how I can treat phantom limb pain, there wasn't really any kind of go-to resources there, which was frustrating. As a clinician, when you can't, when people are telling you on a daily basis of a problem and you cannot really help with it, it is frustrating. So I reached out to Teesside Uni in the northeast of England, because I knew they were working in research into potential therapeutic treatments for phantom limb pain, and that was back 2018. And I kind of left my role as a clinician and went more into the research, into phantom limb pain in general, but focusing on kind of the therapeutic treatment for the condition. And I still work clinically, so I work more in private practice now, private OT practice, on a one-to-one basis with clients going through their kind of amputee rehab journey. And, the client that I'm working with at the moment, she's experiencing a level of phantom limb pain, but like you kind of started off with, everybody's experience of that phantom limb pain is different. So yeah, it's important point to make. everybody's different in their experience of this.
And you mentioned there that you're working with somebody currently that's experiencing phantom limb pain. If we go backwards a step for the audience, because obviously everybody's not here from the UK, what is the difference between an occupational therapist and a physical therapist?
Oh yeah, thanks. So I mean, it's the OTs. I think for years have like kind of historically played the undercard, the understudy kind of thing. You know, the physios are a lot better known, I suppose. You know, occupational therapy is occupation is at the core. So, and by occupation, the misconception is it's work, it's jobs. That's not true. I mean, we do try and get people re-engaged in employment, in work, but the occupation bit is actually meaningful activity. So that again is a very much an individual thing. So it's really very person centered. What matters to the person? What does that person need to do to get through the day, and then what do they want to do as well on top of that? So what hobbies might they want to get back involved with, or start new hobbies, or leisure activities. So yeah, I love my job as an OT because it is. I feel it's provides us with a bit more scope than the physios, who might be a bit more kind of just looking at the physical processes. Yeah.
Obviously, I put in the chat for people to get interactive and to ask
Mm.
questions to us throughout the live stream. So the question I've asked is describe your limb your phantom I can't even read today. Your phantom limb pain.
Yeah.
So obviously you can give a little bit more. It's your opportunity to ask Andy your what particular things you can do for you specifically. So I know that we've talked about that it's on a spectrum, so this is your opportunity watching live, and obviously I'm going to give the guys in the Fit Amputee group the opportunity of the Q&A at the very end that they can ask their questions to you directly, and that's one of the advantages that obviously come the end of this discussion. I'm going to turn everybody else's feed off and we're going to just go for that community. I know that's probably what's happening with the Facebook users coming up. Those are the ones in the group. So I'll let people off this time around because I give the link to follow to make sure they can get their name and their picture up, and it'd be easier to be able to. Oh, this question is coming from such and such. But what was some of the challenges for you, Andy, and how long did the actual process of getting? Because we talked about this only a couple of days ago that you've only just completed
Mm.
your Viva. So I know what a Viva is, but
Mm.
so for people, how long have you been doing this research for to gain your?
Yeah.
I call you
It,
doctor behind the scenes.
I'm not going to. I've got a lot of respect for the medical doctors. The doctor title, I think's best preserved for those guys. But yeah, I mean the work that goes into a PhD is comprehensive. You need to be kind of um, showing a certain level of awareness of the literature. And I designed three studies. So it was the whole, setup process of the studies, then the recruitment, gathering the data, analyzing the data. And this was a full-time job. So as I said, I made that decision. It was a really tough decision at the time, because I did enjoy working in the hospital, in the rehab department. But I thought, this is my opportunity now. I've got an interest in this topic, and there's a team working on it at the local university. This is my time to throw myself into it, and I'm so glad I did that now. Pretty much 4 years down the line. it's been, it was full of different challenges, obviously with the pandemic, and having got two kids, so continuing the research, the work, with that all going on was tricky. But yeah, it's the PhD journey is it's affirming. It's a lot of self development goes on through it. So, and it's only going to add to my clinical skills. I think being aware of what's the latest research out there, what's the latest interventions that might be used, and then getting to speak to groups around the world. So I was just on a call this morning with a guy from Sydney University, who's looking into tele, so as in like online or telephone rehabilitation for phantom limb pain involving graded motor imagery treatment. So yeah, it's just great. Once you get into that research world, you start making networks, and you realise there's different groups around the world who are all working towards the same goal of providing a good treatment for this persistent condition.
Well, we've got a good audience here. Got nine. It's fluctuating between 9, 10 people, so you've got a good audience so far. Considering it's the middle of the day,
Yeah,
early
yeah.
morning for those in the US, and I think it'd be well middle. I don't expect to see the Australians or the Kiwis on here in
No.
the middle of the night. So I've got one person. I'm going to bring the comment onto the screen of Dave. This is where it's going to get difficult because I kind of can't actually pinpoint the exact person. So if you are watching on the live and you do put a comment in the question, be it because of you've not clicked the link to be able to show your name, your profile, put your name before the question or the comment, so at least I can give you recognition for engaging throughout the live stream. Various different phantom pains. I'm sure a lot of it for me is nerve damage I suffered 22 years ago with many surgeries, and before my amputation, I had severe nerve damage that left me with foot drop. Now I'm I'm the exact area I get the worst pain in. Do you see, to follow on from that? I appreciate the person being open and open and transparent with sharing that with on not just Facebook but YouTube, LinkedIn. So I appreciate the person for doing that. Do you find, Andy, that does the literature show if the person has experienced some sort of nerve damage before the amputation is going to be more problematic?
Yeah, so it's an interesting observation, I suppose. That short answer, yes. I think in the chronic pain literature in general, if somebody's lived with a lot of pain, then the central nervous system and into the cortical system might be changed, or might be on a bit more, how I describe it is like kind of high alert. So then, post amputation, that may correlate with the reported intensity of the phantom limb pain. So yeah, there is links definitely between prior nerve damage and then the intensity of the pain post surgery. Yeah, for sure.
And when you say chronic,
Mm.
Andy, would you set that aside from, say, so I'll give you an example. If we put medically chronic pain as
Mm.
opposed to inflammation to do with,
Mm-hmm.
mobility, diet, would
Mm.
you say they're two different things when it comes to chronic pain?
Yeah, so there is a distinction in terms of kind of um, time, like duration. So the distinction's relatively clear in the literature in that um, if 3 months, if the pain's been experienced for 3 months, then we'll classify that as a chronic pain rather than the acute pain. Um, but I like your question because I think it's you got into inflammation is a is one of the key factors that kind of um, contributes to continued chronic pain. So if we think of pain in general, it's just a bit of like a kind of a layperson's kind of um, to try and get people to understand what pain is, then it's an output of the brain, isn't it? It's an experience, it's a perception. So it's very subjective. It's different for different people, and there's so many factors that can impact on influence that. And so if we think about things like diet, um, exercise, all these, the social factors, what kind of environment people are living in, and if there was kind of social factors that influences people's lives, this all contributes to that output, that perception of pain. So there's the approach that I take to the treatment of phantom limb pain would always be around self-management. So it's very much about kind of coaching the person to be able um, to think about all those factors in their lives that might be impacting on and the output of the pain experience.
Do you think that, and it's quite interesting that you say obviously information is a good contributor. So it's I think from my profession, obviously I would look at mobility,
Mm-hmm.
nutrition. Uh, it's a challenge, obviously, for amputees because they're all at different stages. And I don't know, my hands out of shot. Different levels of at their journey, and what I
Mm-hmm.
mean by that is obviously, and I try to explain that explicitly to my clients is if you looked at somebody's video on Facebook, you might not be having the same starting point. And I think where
Mm-hmm.
you mentioned that from uh, a pain incident is very subjective in terms of somebody might be, if we gave a scale of 1 to 10, somebody might be higher up that spectrum. I'm not going to give a number because that's
Yeah.
a bit judgmental, but versus maybe somebody else might fall further down the spectrum, but their pain is very similar. And phantom limb pain is obviously you've got two individuals. One side is going to suffer with it, and obviously the other side of that picket fence is going to be a lesser degree or not experience it at all. So I think when you mentioned that, I'm very surprised that chronic pain only sets in after 3 months. I would have thought acute would be a lot, and the people don't know what acute is. It's a short period of time, and it's not as impactful on your day to day living. I would have thought that would be less than 3 months, a lot less than 3 months, be it a few weeks.
Yeah, I mean, just to clarify that, I suppose you post amputation, if you think of all the kind of what goes on in an amputation, with the surgery itself, the cut, cutting through with the nerve fibers, muscle tissue, and everything. We would, you obviously expect an acute response. You expect a period of inflammation, a period of kind of pain, but we what you expect and what sometimes might be the general course um, Post amputation is the residual limb, the tissues is all settled down, or the neurons have started to settle down, and there's no particular kind of reasons why there should be an experience of pain, but phantom limb pain says otherwise. It's the pain is there. 3 months, 6 months, 12 months, up to I speak to guys 40 years down the line who still experience phantom limb pain. But on that point, and linking into the point there, the comment on Facebook, I think it's important to distinguish between people who are experiencing residual limb pain, or colloquially as patients call it stump pain to me. I don't, they talk about the stump. I think that's fine. I roll with stump as a term. So if people have got stump pain, that's very different mechanisms and very different experience of pain to phantom limb pain. They might actually, the stump pains are usually due to kind of neuromas, like the underlying nerves still firing off very randomly in causing a pain experience. But as I say, that's different to the phantom pain. And then, like it says here, it's pins and needles and squeezing sensations. So the distinction that's again been made in the literature and from my clinical experience, people talk about they've got phantom sensation, which I think it's a very different thing to saying I've got phantom pain. The phantom sensation might be slightly uncomfortable, but it's not really going to impact on everyday activities. Whereas it's those flare-ups or those real strong episodes of a guy I was at an amputee rehab conference the other day, and there was a guy coming on who had been in a horrific car crash. I seen the photo of the aftermath, of the it's horrible, and he's only a year post amputation. In his experience, he says up to 12 to 14 hours a day of these flare-ups of phantom limb pain, and he described it as a serrated knife being run across his Achilles tendon, which is no longer there. And so my clinical experience is clients describing the phantom pain in metaphors. Another common one is so the pins and needles, squeezing sensations. Yes, that seems to be a commonality. But the electric shock type pains in the phantom limb. So maybe it might be in the toe or the ankle that is no longer there. But that specific type of pain is causing distress and causing people's problems. The metaphors are actually quite useful as a clinician and a researcher, because we can start to kind of pinpoint what we're trying to treat. So,
And when we talk about actual treatment, Andy,
yeah,
why is one of the I'm going to say one of the techniques, if you look at the literature, to overcome or to deal with phantom limb pain, why is the mirror technique
yeah.
being so successful down the years?
Yeah, I mean, so I would say, having looked at the literature, it's mixed, definitely mixed results, and that matches with the clinical experience. I wouldn't say it's certainly not like a gold standard treatment, and it won't work for everybody. But the idea is that it's kind of the mirror image of the intact limb, then kind of works on the brain. To put it kind of simply, it works on the brain's representation of the body. So, um, so if the brain's thinking, actually, there's a mismatch between what was the blueprint of the limb and the actual physical limb. Well, actually, now if I look at that mirror image and the limb looks fully intact, then the brain's like, okay, that's yeah, there's no danger going on there. It's kind of, so it's the idea of um, tricking in the brain um, into thinking that this new limb doesn't need protecting. Um, I'm not an expert in mirror therapy, and probably guys who are would probably explain it a bit better than that, to be honest. But it's, for me, mirror therapy is, it's about kind of reorganizing the brain. Yeah,
For when I've seen it, Andy, it's I think I'm very, people might disagree with this a little bit sometimes, but I'm quite logical.
yep,
I find it very surprising that you can manipulate your brain to think that, okay, my prosthetic leg is my um I don't know how to term it. The leg I'm missing is my left leg,
yeah,
and the good leg is my right. So if I looked in a mirror and I saw my
yeah.
right leg being reflected, it's not the true representation of a left that's missing. So do you have to go in with it with maybe more of an open,
Yeah, no,
like,
I
approach?
totally agree. And I totally get your point, and that's one of my main criticisms of it. And I don't think well, I don't use it as a definitive only treatment. To be honest, I think, as I say, the results in the literature aren't great for it. And there's a question there: how long does it say mirror therapy takes to work? There's no definitive answer on that. There has been randomized control trials done, so that like kind of gold step level trial where they might do a protocol over 4 weeks and see like an improvement, but then there's not the long term data, so we don't know 12 months down the line if
The,
it's
so
actually worked.
the challenge with that, this is probably where my maybe having gone to university helps to challenge that, is that's a control setting, and for you to, so to give you, I'm gonna break it down for people watching to make it a little bit more simplified. The randomized act is just picking things at random and then cross analyzing them. So it's not a real life scenario, because you'll
Yeah.
have the amputees go into a university setting and it's controlled. So it's good to be able to compare research,
Mm.
but the practical I can't get the word out. Implications are not always that so clear cut. So
Mm.
when I think when you answered the question quite nicely of how long does it take, it's almost like the question is how long is a piece of rope.
Yeah, yeah, yeah. Yeah, yeah. It's the same in like all these studies that to make it really fair trial, and because everybody comes to the table with different um, influences and different factors, different characteristics. So you never want to it's never fully even at like the kind of at the start of the trials, and they usually don't. The data isn't collected for long enough to understand actually what the long term effects of the treatments are.
Oops,
Oh, is
that's a
that,
bit. It's
yeah,
not. It's only something off in on the side. It's nothing. Nothing that bad. So if
yeah,
there's a loud bang, hey, don't worry about it. It's only something falling off the side.
but
I
yeah,
appreciate the question being asked, and I don't want to be condescending about how I said, but by the length of a rope is that I
mm,
do apologize by that comment. So it's probably someone wondered if you looked in the realms of, say, meditation,
yeah,
mindfulness, things don't, and I think this is the problem of society to a certain extent of, people want the instant results, instant success. It's patience, and as you mentioned earlier on, it's not going to work for everybody. And this
Mm.
will be my follow-up question: Why is it like an even split? If right down the middle of it's going to work for some people and not work for some, or is it very ad hoc?
Yeah, I'd say it's probably more ad hoc. I think what the mirror therapy on its own, it's been developed on. So there's now a treatment called graded motor imagery, and that's like a 3-step process. So actually, the last step is mirror therapy. The first step is limb laterality judgment task. So deciding if a limb is left or right. The second aspect is explicit motor imagery. So actually, that the idea of like kind of picturing in your mind's eye, the phantom arm or leg, in trying to get that to move. And then the third aspect is the motor therapy. So it's all working on these the processes in the brain, the cortical areas in the brain. And yeah, go on.
This probably, and I appreciate the person following up to that question they asked. Do you think they need to take those two? Because I didn't know there was a 3-step approach to that particular technique. Do you think
Yeah.
they need to take a look at the previous 2 steps to give a bigger overview of the technique as a whole? Because if I read the question, uh,
Yeah.
is that is they're trying to find various techniques to reduce pain. I want to know when to give up on that particular technique.
Mm. Yeah. You know, this is the issue we face at the moment. There's no good um, evidence for treatments working well for people, and with that, there's no clear kind of protocols on how best to do it. So this is the situation that we're at now, and unfortunately, people are just trying different things, maybe probably not guided by a clinician, just maybe from information they've read on the internet, or from somebody that they've spoken to. Um, so yeah, there's a need for
Oh no.
more development of these treatments, and better quality trials to then hopefully down the line being able to go like, look, this is a well designed, and the evidence for this treatment is pretty solid. It's pretty robust. Um, so yeah, and this came through. So in part of my PhD, I did a qualitative study. So I was asking people questions about their experiences of self-managing, and that's what was coming through strong. It was like, oh yeah, well, I've heard about mirror therapy and I've tried it a bit at home, but I didn't really know what I was doing. And or just the massage of the limb. Um, if people find relief from that, or wearing like shrinker socks or something. So providing that that feedback from that might work for some people, but yeah, it's unfortunately, and again, it's frustrating as a clinician that I can't say, look, this is what um, this is what I want to treat you with, because I know it works, because we're not quite there yet, but there is research going on. As I said, yeah, creative motor imagery um, has potential. There's something called phantom motor execution, which has come through from some researchers in Gothenburg. Max Ortiz Catalan, his lab out there, and that's really interesting. So it's actually building on mirror therapy, because it's that's to do with augmenting. So it's getting into the realms of like virtual reality and augmenting a virtual limb. So it's kind of, you can visualize that limb and you can get control over the movement of the phantom limb. So all these are kind of working on those cortical processes. I keep looking at Rex's question, and it's a really good
I'm
topic.
gonna bring it up.
Yeah, because it's a really good, and I'm going to be a total cop out and say that I don't know. I can't give a good answer to that because this is still being debated by the neuroscientists. So again, for me, it's like I'm a clinician. What I do is I rely on the neuroscientists in the labs to do, specific tests, usually where they do fMRI scanning. So they're really getting into the nitty gritty of the neural correlates of phantom limb pain and actually what's going on at a cortical level. But yeah, that's not my field. So I'm just kind of, I've been to conferences where they've been talking about this homunculus chart. And I'm confident that that's a good target area. So the homunculus chart is, there's a question that's just popped in there, is basically we're born with a blueprint of all our limbs, all our body parts in the brain, and that's been a neuroscientist called Wilbur Penfield mapped this back years and years and years ago, long before I was born, and it quite nicely. There's nice graphical representations of it, which you can get online if you just Google sensory homunculus. They call it the little person in the brain because it's all your body parts mapped, and you can see which regions are beside each other. So the arm and hands and fingers is beside the lip in the mouth area. When you go to the leg, so the leg and foot is actually next to the genital area. So you can see a nice representation of the blueprint of your body parts in the brain. So now then, if you think, well, post-amputation, what's going on with that blueprint? Has it changed? And that's where the debate's going on. So some of the neuroscientists are saying, look, that blueprint's kind of preserved. Or that blueprint's taken on the form of the phantom limb, or actually there's something called cortical reorganization, which a neuroscientist called Herta Floor is kind of pushed for years. And she's saying that actually these areas in the brain post amputation are getting like smudged. So the arm area is actually getting smudged into the face area, which is really interesting. And if anybody's heard of it, it's a neuroscientist called Ramachandran. He's written a really cool book on phantom limbs and done lots of experiments. Probably back in probably in the 90s, I think, or early 2000s. I'm not too sure on dates, but he was able to show that when you stimulate certain areas of the face, there's a reaction in the phantom arm and the phantom hand, and vice versa. So as you can tell, I love all this neuroscience stuff, but as a clinician, I'm just following the debates and following the developments. I'm not really involved with that. But what I'm interested in is how can that knowledge be transferred into treatments. And yeah, so just to go on from there, how can that be transferred into treatments? Our group at Tayside Uni are keen on investigating sensory discrimination training, and that's looking at actually reapplying a stimulus to the residual limb. So, and it's very like direct stimulus based on like attaching electrodes to the residual limb and targeted electrical impulses, and then the person has got to decide what the location of that stimulus was on their stump, and also about if it was like a kind of um, it's a haptic feeling. So was that haptic? Was that feeling like a short burst, or was it long and continuous? And then there's feedback provided about how accurate that person was in judging that stimulus. So that's where what we're trying to investigate, because we're trying to think if we provide the amputee with the stimulus that has been lost due to the amputation, can that have an effect on the cortical changes? So we're looking into developing a trial around sensory discrimination training.
You mentioned a good topic about, if we come back to him, I'm going to struggle with the word.
Homunculus, yeah.
Homunculus, because one of my clients, he was bringing it up of either he's got phantom limb pain or he needs to go to the toilet. So when you say that they're closely linked together, for me that makes sense now, because
it does, yeah. And that yeah, I've had plenty of people saying, what we call in the clinical world maturation. So yeah, passing urine is linked to then a phantom experience in the leg or in the foot, in the phantom foot or phantom toe, which makes sense, with that cortical smudging. And anecdotally, so I've read this about orgasms as well. So people experience kind of either stronger orgasms or a kind of a change in that experience, again because of the potential of that change to the homunculus post amputation. So it's super interesting stuff. Yeah.
And you and I discussed days ago about Dr. Demanion's pioneering TMR procedure. How did it differentiate between the two that we've already discussed so far? I know you
Yeah.
said to me you weren't an expert in that field,
No.
but from your own observation and
Yeah.
opinion, how does it slightly differ from what we've discussed so far?
Yeah. No, good question. So for people that probably most people aren't aware of this procedure called targeted muscle reinnervation, so TMR, which it can be done at the time of amputation, and it's basically let's put it simply, sewing, because I'm not a neurosurgeon, so I can't describe it in detail, but sewing the cut nerve back into a nerve, a muscle area that is still that has been de-innervated, so has been so is like kind of no longer firing, if that makes sense. So the idea is actually this nerve that's been cut through now has something to do again. Yeah, it's kind of it's not just firing off randomly. It's now being reinnervated into muscle, and it's doing its job again. Now the guy who actually pioneered this, Todd Kiken, who's a retired neurosurgeon now, but I heard him talk at a conference last year, and his work's out of Chicago, his lab out there, and they're doing some really good work in TMR, and find they've published some pretty good results on if people have had TMR, their self-reported phantom limb pain has been improved. And just to say it's so well, I'll say this first, and then I'll put a big caveat in. So it's also being used with the new myoelectric prosthetics. So they're actually, the neurosurgeons are able to wire those nerves up, sew those nerves into the into the prosthetic to bring extra control of that prosthetic. It's mind blowing stuff to me. It's fascinating, and these neurosurgeons are amazing people. But what the big caveat is, look, it's not widely available, and I can speak for the UK amputee population and saying that it's very few people have had this surgery. I think there's only a few neurosurgeons in England who perform it. So, but like everything, once it becomes these things become more mainstream, don't they? So yeah, TMR is one to follow. Investing procedure.
That's interesting because obviously I share that person from coming from Illinois. So that's for you in particular, that's maybe a person to look out for
Yeah,
because that's in your backyard.
yeah.
Why do you think, Andy, that we to a certain extent are, I'm not gonna say behind the times in the UK compared to the US?
Mm.
Why are we playing catch up when it comes? I know we've got both a public sector and a private sector, and
Yeah,
you and I know both know
yeah.
that. But shouldn't it come down to, and I've been asked this question down the years of people that are dealing with pain, like chronic pain, and are looking to go down the elective route, and they've asked me, well, what do you think I should do, James? It's like, well,
Mm.
it's a discussion between you, the doctor, and the surgeon. It baffles me that they don't look at what is going to give the person the better quality of life.
Yeah.
If losing half a limb, leg, arm is going to improve their life, maybe you should look at it versus, oh, it's
Mm.
not maybe best for them. It's like, well, if their quality of life now is poor
Mm-hmm.
because they're in pain all the time and uh, have all their body parts functioning. As you're the only person on this,
Yeah,
as a
yeah,
recording. Okay, on my Facebook, my personal profile, there might be other able-bodied people watching, but most of the people watching will be missing some sort of limb. Why do you think the clinicians don't always look at that scenario of what is the long road for that individual if we did chop something off?
well, yeah. I mean, that's it's quite it's quite a loaded question, and like in terms of like um, it has to be on an individual basis, and as a therapist, I'm not high enough up the pay scale to make that kind of decision. Obviously,
Right. I think somebody saved your bacon there. Look, risk versus reward.
yeah, for sure. I mean, what I would say is, look, phantom limb pain is a common condition. So, so say somebody's experiencing chronic pain prior, experiencing chronic pain, and they go down the elective route. It's really important that we'll make this person aware that they may then be experiencing phantom limb pain. They may experience residual limb pain. Um, the 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 interesting kind of controversy, I suppose, that I'm following is around people who are living with complex regional pain syndrome, and asking for going around going around the houses to asking different surgeons to do an amputation, and I think that's the tricky one for me. You know, how can you say that you're going to be paying free after? Um, but because so with CRPS as well, because you know there might be then the person might be left with CRPS in their residual limb. So it's a tricky one. But I think to put to it, you know, I suppose I'd be preaching to the right crowd and saying that, you know, post amputation life can be great, life can be enriching, life can be, you know, it might be, you know, for me as an occupational therapist, it's like, right, you know, what is it that you want to do now post amputation? You know, is it kind of sport, you know, sports that you want to get into? Is it hobby? You know, what hobbies are, you know, that, because I think with any pain condition, there's an element of distraction being a really good thing, or an element of just being so, you know, so engaged with a hobby, whether that be sport or something else, that actually um, life's fine, and I can deal with this little bit of underlying pain. If that makes sense. Um, yeah.
But coming back to what we were talking about before of the TRM procedure, the person is asking. This is where it gets difficult because can't name the person by name. What about in the US? Do you know? Obviously, that Dr. Demarin is a US surgeon.
Mm.
I know of this procedure because of Cozy Talks. Cozy, I'm not gonna pronounce his surname because I can't remember how to pronounce it.
Mm.
But she's a physical therapist
Okay.
in the US, out of Florida, and she interviewed him. So if you haven't seen that discussion on Cozy Talks, obviously go and watch it. I've only watched a brief bit of it. That's why I know that procedure exists.
Yeah, I mean, all I can add to that is my, when I heard Todd Kuiken's talk, his lab is in Colorado, and it's called the Shirley Lab. Um, so that's my knowledge that those procedures and the research into TMR is probably being pioneered out of that, out, out of there. Yeah.
So we're coming to the close of this live stream. Obviously, I've changed my mind and I've left it to go to all other platforms because the technical difficulty at the beginning with the other one. So I'm gonna have to go away and delete that feed for everybody, so you don't have a mistake and we're not talking. And obviously, for those that have been on throughout the live stream, it's massively appreciated that you've stuck out for what is now, if you were on the other feed, and now a plus. So thank you very much for tuning in for that period of time. And obviously, I'd like to thank Andy for taking the time out of his busy day to come and speak with us today.
Yeah, no, thank you. It's been a pleasure. Yeah.
And if anybody who's obviously watching this on the replay, Andy is actually in the group. So if you had any additional questions, obviously put it in the comments. If you're not a part of the group just yet, I will link it in the comments on my Facebook page, LinkedIn, YouTube, so you can come and join that thing and be able to ask Andy directly your
Yep.
questions, or if you preferred, I don't think you'd mind if they'd message you privately if it was more, they felt more obliged to do that.
Yeah, that's absolutely fine. Yeah.
So once again, everybody, thanks for joining. Look out for more videos like this in the near future. So take care, have a good one, and see you all soon.